Great. Thank you very much. I'm really pleased to introduce Virginia Newcombe this morning. Dr. Newcombe is a consultant in emergency medicine and neurocritical care at Addenbrooke Hospital in Cambridge, and she's done a lot of research looking at prognosis and how we can better determine outcome after traumatic brain injury. So welcome, thank you very much.
So I'd really like to thank you for having me here today. I have to admit, as an emergency physician and an intensivist, there's very little that phases me, but I'm absolutely terrified to be talking at a conference full of psychiatrists and neurologists. So please be gentle. So I'll just declare one conflict of interest. I do hold a grant with Roche that's to do with biomarkers. Nothing I'm talking about today has anything to do with that grant. And I'm going to be talking about traumatic brain injury. So Andrew Maas, who's a neurosurgeon in Antwerp, was the first person to actually say this, but I think it's very true about traumatic brain injury. So it's the most complex disease and the most complex organ. So what I am going to talk about today is I'm going to try and tell you where the field has been going over the past few years, how some of our perceptions about traumatic brain injury are changing, in the hope that that might give you some things to think about when you see a patient after a TBI. What I'm not going to do, because I'm in front of such an esteemed audience who are experts in this already, I'm not going to talk about functional neurological disorders. But I'm going to go through some of the beliefs that are out there about head injury. So there is this very common perception, and emergency physicians were actually people who believe this quite strongly, that a mild head injury resolves quickly. So you have this head injury, you should get better within a couple of weeks. The NICE guideline tells us that the majority of people should be better within 3 weeks. However, when you look at the large cohort studies of patients who come through with mild traumatic brain injury, so this is an example from TRACK TBI, which is a large cohort study done in America over the past few years, you can see that even out to 12 months after their head injury, about 50% of patients will still have symptoms that they attribute to their head injury. And this is higher than those, so they've got some orthopaedic trauma controls there. And if we look at the Centre TBI data, so Centre TBI is a large European study that I've been working on with a large number of other people over the past few years, on about 4,500 patients. If we look purely at those patients who have a normal head CT and are discharged from the emergency department, there's incomplete recovery on the Glasgow Coma score, outcome scale extended, so a GOSE of less than 8 in 30% of these patients at 6 months after their initial insult. And if we look at some data that was collected in Cambridge, we can see that these patients tend to plateau with their deficits at about 3 months after injury, but even up to 2 years after injury, they still are often complaining of many symptoms. And these are just some of the symptoms that these patients might complain about. So on the right-hand side of the slide is the Rivermead post-concussion questionnaire. And I bet you're looking at that and thinking, actually, I relate to a lot of these. I certainly feel fatigued most of the time. I'm feeling a bit nauseous now because I'm giving a talk. You know, these are pretty common things. And if you look at the general population, it's true. A large number of the general population have these symptoms at any one point in time. So how do we distinguish between those who have effects of a head injury between those who have just the effects of just being alive? So we need to look for some objective markers of a traumatic brain injury. So I'm going to talk a little bit now about some biomarkers. I'm going to talk in particular about proteomic biomarkers, as that's the most commonly studied biomarkers at the moment. So the ones that are currently most studied are UCLHL1, a neurospecific analase from neurons, neurofilament light and tau, and GFAP and S100 beta. And if we look at patients after a traumatic brain injury, we notice a couple of interesting things with these biomarkers. So this is work done by one of my PhD students, Dan Whitehouse, in the European trial, Centre TBI. And he found that the lesion type is not related to the elevation of these biomarkers, even though they come from all of these different cells, but it's actually the extent of lesion or the burden of injury that these patients have. quantified by both the number of lesions, different types that they have, as well as the volume of these lesions. But what I found really interesting in this data set, because we often have this perception that if you have a skull fracture, you don't actually have a brain injury at all. But in the patients who had an isolated skull fracture and a normal head CT, even they had an elevation in their biomarkers. Can we look at it in a slightly different context? So if we look at GFAP, so glial fibrillary acid protein, we can and look in those patients who have a negative CT, so a normal CT when they come into an emergency department, then we can actually use GFAP in order to predict which patients will have lesions, so occult lesions on their MRI. And if we look closely in this paper, again, I think there's a really interesting point here, that those who have a negative CT and a negative MRI clearly have an elevation in their brain biomarkers over and above people who are orthopaedic trauma controls, so have just had a fractured ankle or a fractured wrist or so on. And so I think that's quite an interesting point in terms of sort of some evidence of brain injury in the more mildly injured patients. Now, emergency physicians, despite the fact that we've got all of those ambulances out the door, queuing for hours to come in and see us, we are optimistic people. And so we like to think the majority of patients that we see and we send home will get better. But I've already told you that a lot of these don't. And so maybe we need to, as emergency physicians, change our thought process about so at the moment we assess a patient, we do a head CT, and we're really trying to assess, do they need to see a neurosurgeon or not? Do they need to be admitted to hospital? But maybe we actually need to start predicting which of these patients will have ongoing symptoms, because then we may be able to actually do some earlier interventions and prevent them from becoming entrenched. But we're really bad at this prediction. So the current best models for prediction of mild traumatic brain injury outcome come from the upfront study, which was done in the Netherlands. But that relies on premorbid factors, so what the patient brings to the injury, as well as factors of symptoms at 2 weeks after their injury. The 2 weeks is too late to do prediction for a number of reasons. One, the patient's already been unwell for a couple of weeks. But also the volume of these patients coming into an emergency department means we cannot follow them all up at 2 weeks down the line. So we need to look for better ways of predicting their outcome. Now, MRI is something that could potentially offer us a way to do this. Here's some data done from another of my PhD students, Sophie Richter, where we looked at patients who had 2 MRIs after their mild head injury. So the first MR was within 72 hours of their injury, and the second MRI was 2 to 3 weeks down the line. Now, perhaps not surprisingly, we found that the earlier scan is much more predictive than the later scan. This fits with what we think is the pathophysiology going on. So we think, if there's some edema, by 2 to 3 weeks it will have resolved and we won't be detecting it on the MRI anymore. What we also found was it wasn't the presence of lesions or not, so what the radiologists would look at, that was useful in terms of predicting the outcome in these patients. It was using more advanced imaging techniques, such as diffusion tensor imaging, that really added that value of prognostication. So I've spoken a little bit about outcomes, and I just wanted to think about, are we actually measuring the correct outcomes in this patient group? So here is a whole list of different outcome measures that we use, which will be familiar to many of you in the audience. And if we focus on the 2 most commonly used in mild head injury, so the Rivermead post-concussion score and the GOSC, we can see that the Rivermead clusters with mental health symptoms that the patients have, whereas the Glasgow Coma Score Extended functions with clusters with disability and the physical symptoms of a patient. And so both of these scores are measuring very different things. So do we need to measure more things in these patients, or do we need to be a bit more clever about what we measure in these patients? What is important to the patient? And I'd probably say getting back to what their normal activities were is probably, in my experience of talking to the patients, the most important thing to them. Are we also measuring enough? So here's some data showing that it's not just the mild head injury that predicts your outcome or portends your outcome. It's whether or not you have an extracranial injury associated with it. So if you have a mild head injury and you have a limb injury or other injury, then you're much more likely to have a disability, level of disability that's closer to that of those with the more severe head injuries. And so we perhaps need to start thinking about measuring our extracranial injury impact a little bit more, particularly in the research setting. And so there's been a lot of debate about doing a Glasgow Coma Score extended using the whole patient and what's going on, or trying to attribute their disability to the head injury. And I think there's a lot of problems there, but it's certainly an interesting concept to explore. So mild head injury itself is extremely complex. So I put this up here. It's a very busy slide, but it's just to show just how complex it is, and how it's what the patient brings to the injury as well as what the injury does. That's really the important things that cause the outcome in these patients. And I think it's important when thinking about these patients to not be really nihilistic. So there are lots of things we can actually do for these patients to improve their outcome. So for example, one of the most common complaints that they have are migraines, and if they're treated, then often they end up with a much better quality of life. So one of the beliefs, certainly in head injury that I've come across, is that the outcome that you have will scale with the initial severity of injury that you have. So that if you come and see me in my intensive care setting, you get ventilated, you sit in the ICU for a number of weeks, then you're always going to have a much poorer outcome than someone who has a more mild injury, so they either went to the ward or went home. However, when we look at the Centre TBI data, we see that clearly, this is true to an extent. So patients who end up in the intensive care unit, 83% of them will have a GOSE of less than 8, so an incomplete recovery. And 30% of those who go to the emergency department will also have this incomplete recovery. But what I think is really interesting here is when you look at the SF12 and the Qualibri, so these quality of life scales, and look at the mental health component and the physical components, we can see that there's really no difference between those who were in the emergency department and went home versus those in the ICU. So there's a little bit more in the ICU, but this is really disproportionate to what you would expect for the severity of injury. And so it's not necessarily true that the severity of injury corresponds to the outcome of these patients. So we need to better stratify what actually is an unfavourable outcome in these patients, and it may be different unfavourable outcomes for different groups or cohorts of these patients. And we also need to try and assess better the mechanisms of what causes these differences between these different groups. Now, if we look at the outcome of these patients, we can see that the physical deficits that these patients have correspond very closely with the amount of disability that they have. But it's really quite clear that the mental health issues that they have really corresponds, is critical in obtaining the better outcomes in those with the less severe disability. And that cognitive deficits are pervasive across the group. However, it might be that in this sort of less favourable outcome group, the cognitive deficits that help drive some of that disability that occurs. We also have this belief that disability correlates with the quality of life. However, in this group of patients, there is some discordance here that we find. So if we look at those patients with mild head injury and with a severe head injury, classified on the Glasgow Coma Score, and we look at their outcome, we can see that those with the more severe disability outcomes have more than 50% of them will have quality of life scores or SF12 scores in the mental health domains that are back towards sort of in the normal range of these scales. Whereas if we look at the physical disability of these patients in the more severe end of the spectrum, again we can see that there's a much lower proportion of patients who have normal scores. And so you have this discordance between the physical and the mental health components and the quality of life components. And this discordance of about sort of up to almost 10 point scale difference is actually more than one standard deviation in the general population of these scores. So there's clearly something going on here for these patients. And so now I'm just going to talk a little bit about sports concussion. It's extraordinarily topical at the moment, and I think it's only going to get more topical over the next few years. And there's been this belief that sort of having subconcussive hits or mild head injuries, where you might get a little bit concussed on a weekend, but you're okay by Wednesday, have no significant long-term consequences. But there's a growing appreciation that this accumulation of events may actually lead to a syndrome that's commonly called chronic traumatic encephalopathy. Now, you know, as we can see here, you know, this all really kicked off in terms of being in the media in the sort of about 10 years or so ago, when Anne McKee did that great case series of patients in the US. It led to the NFL doing a payout, but let's be honest here, $1 billion for the NFL is not much money at all. You know, this was just taken yesterday. I took the screenshot from The Guardian showing that it's really still up there in the news. And I think, but, you know, it's not a new thing. So actually describing the fact that repetitive hits over a long term was actually first described in the 1920s. So this is a neuropathologist in the US who recognised it quite early on. It was recognised in the sporting associations of America very early on. So this is from the 1933 Collegiate Athletic Association manual. And this manual was actually used in the case against the NFL to show that they've known it for decades, so why haven't they done anything about it? And yet we're still trying to gather all that evidence to prove this concept. So in the sporting arena, this consensus statement is really important. So it's what a lot of the different sporting bodies will put their guidelines on as to when a player should return to play, what they should do if they get injured, and so on. But I put it to you, it's quite a controversial document. So it consistently has said, and this is actually the 2016 is much more toned down than the previous editions, but even then it still says that, look, we don't really know what causes CTE. Sort of gives this air of the fact that it's not really that believable as an entity. But this is actually paid for by the sporting bodies. So you can read into that what you will. And there's currently a controversy going on in that the first author of the previous 4 guidelines is currently being investigated for plagiarism and for his links with sporting world. So I think there's a bit of a watch this space, and it'll be very interesting to see what comes out in the consensus later on this year as to what they actually say about CTE. Now, I mentioned earlier in my talk that the length of time for recovery from mild head injury is probably longer than we have traditionally appreciated. And those guidelines have consistently said that you should actually get over your concussion within a week. It's very convenient. It means you only have to miss 1 round of sport, maybe. But actually the evidence says that if you have a significant hit, then it will be sort of at least a month or so. And the younger you are, so sort of teenagers and so on, tend to take longer to recover from their concussions. This is some really nice work led by Willie Stewart up in Scotland, where he's taken a big database that's available up in Scotland and very elegantly shown that if you're a professional football player, then you've got a 3.5 times the risk of a neurodegenerative disease than if you weren't a professional football player. Now, clearly this is an association, it's not necessarily causal, but it's sort of a very important link to have a look at. And it appears that it's where you play that it really does have a great effect on your risk of having CTE or this early onset dementia, and the length of time that you have your professional career. So if you want to play sport and you want to be safe in football, you probably want to be the goalkeeper rather than anyone else on the basis of this evidence. So with this growing interest in CTE, you know, so sort of traditionally, even from the 1920s, it's been a histopathological diagnosis. You cannot diagnose it unless a pathologist looks at your brain. Clearly not that useful when you're actually trying to treat people with this condition. So there's now a movement to sort of diagnose potentially that's sort of being called traumatic encephalopathy syndrome. And NINS in the US has put together some guidelines for potentially diagnosing this syndrome. Interestingly, these guidelines don't actually have any biomarkers, so there's no mention of MRI or other in there. So I think this is really an evolving space, but it's a good space to start. And there's certainly a lot of interest in, and there are some large cohort studies now beginning in sportsmen and women, where, because we're going to have to follow them over many years, potentially do MRIs, biomarkers, or what other biomarkers you think are useful for these patients. And so, maybe in 20 years' time, we'll be able to stand up here and say that there definitely is a link between repetitive head injury and a chronic traumatic encephalopathy. So I guess that's just a bit of a whistle-stop tour through some of the changing concepts in head injury, ranging from the fact that mild head injury, sequelae may last for longer than we originally appreciated, that we are starting to get some objective markers for this brain injury that's occurring, and that we really need to think a bit more carefully about how we measure the outcomes in these patients and get some more meaningful outcomes for the patients. So thank you very much for listening to me, and I'd be happy to answer any questions. Thank
you very much. Are there any questions?
There's one more.
I'll just grab it. Sorry, it's you.
Thanks very much for that. It's just a definitional point, really. I was interested in your comment about MRI scans showing edema. So if an MRI scan shows edema after a TBI, does that put it into the moderate to severe category, or is it still in the mild category of your using those criteria?
So I think it depends on how you're defining your head injury, doesn't it? So I think most people would classify, if someone has a normal CT and a GCS of 13, 14, 15, then traditionally you'd call them a mild head injury, and you wouldn't normally do an MRI. So then the debate is whether or not what you would then call it. So certainly if someone has a GCS 13, 14, 15, and a CT that's positive, so has a lesion present on it, you have this concept of a complicated mild head injury. So maybe these patients fall into the complicated mild head injury group. What's quite interesting in the Centre TBI data is if you look at the patients who have a complex or a complicated mild head injury, so they have a lesion on their CT, versus those patients who don't have a lesion on their CT, their GOSEs at 6 months are actually almost the same. So even if you don't have an objective lesion, you still can have some form of a problem going down the line. But I think the definitions of head injury are sort of a big can of worms, but an interesting can of worms, because then you have other classifications that take into account post-traumatic amnesia and other things as well.
I guess I'm just really making a comment because I do a lot of workplace assessments for head injury, and quite a lot actually. Where I work, I do the primary neuropsychiatric assessments for people who have had injuries in the workplace, and this ranges from anything from a pen dropping on your head at work to having a catastrophic fall, which reduces, you come in with reduced GCS, you have MRI changes, and they're all categorized as mild head injury. And my worry at the moment with the CTE movement, and I work in North America, is that everyone now has a CTE, and no one wants to go back to work even if they've had a pen on their head, because many do fit into that category, the means category of multiple injuries. So they might have had hockey, they might have had a ball injury in their head 2 years ago with hockey, and then they've had this pen fall on their head at work. And so, while it's an evolving field, my worry is that all this group of patients who are becoming more and more disabled because they think they've got this catastrophic injury, and maybe we need to be more clear about which group, and maybe that's where the research should be, about whose disability is actually non-reversible versus the people who can actually go back to work and function and have functional recovery.
I think it's a really interesting point, and I think there's a couple of things there. So the first is that most head injury studies, so like most of the studies I've presented here, to get into them and be recruited into them, you have to have had a head injury that was severe enough that under your local guidelines you needed to have a head CT. But we know that lots of people don't need a head CT, but they don't get recruited to studies because it's at what point do you say that head injury wasn't significant enough that I'm not interested in them as a researcher? And so there's actually this cohort of patients in the acute phase that have all of this missing research. And so we need to do that research in these more milds in order to understand some of the things that you've commented on. The other thing is, most of us are going to have repetitive head injuries, aren't we? If you look at the statistics, 1 in 2 of us are going to sustain some form of a significant head injury, however you might define that, over the course of your lifetime. 1 in 2 of us. So, chances are we'll probably have other hits as well. So it's at what point does the repetitiveness actually make a difference and actually cause a permanent damage? That we have no answer to, and without huge, longitudinal cohort studies that sort of quantify the dose of impact that these patients have, we won't be able to answer that question. But I think it's a good point to think about with these patients.
Great. Okay, and I think we've just got time for one quick one from Thomas.
Hi. I guess I'm wondering, given what you've shown about the recovery being a bit more prolonged from mild TBI, what should we be advising these patients when they come to us in the acute phase about what to do? Is there any evidence for rest? Is there any evidence for taking time off work? I'm just going twice a month I'm phoning from my daughter's school saying she's fallen down on the playground, she can't do sports for 2 weeks. Is there any evidence for that kind of thing?
So I think the evidence out there is pretty weak. So the best evidence is, and this is why the NICE guidelines are written the way that they are, that if you give someone some information and you tell them that on the balance of probability they're going to get better, so don't worry about what's happening to you in the acute phase, you're more likely to get better. And that's pretty weak evidence if you actually go back to the original papers describing the RCT that did that. In terms of length of time off play, again, that's a really weak evidence area. Do you want to have someone off until they're no longer got symptoms? But if you want to play sport, you might game that system. So those studies have got a lot of biases in them. Or do you wait till after they've not had symptoms plus a bit extra time, but how long is that piece of time? And so most guidelines will have a wait till you're symptom-free, then do a graded return to school or work or whatever your activities are. But actually, when you look at the evidence, it's pretty weak. So I couldn't give you an actual timeline. And when I see patients in the emergency department, I'm actually quite honest with them. But I do, because the best evidence is there that they are going to, 70% of people don't have ongoing symptoms. So I tell them that on the balance of probabilities, they'll be fine, because that's the evidence I've got. But in terms of how long to stay off, it's a very contentious area, I think.